Hi, I'm Roger Dmochowski.
Gary Lemack.
We're here to talk to you today about the process of FPMRS certification and recertification as it exists currently. As you know, we've had a separate subspecialty that has been co-certified by both the American Board of OB-GYN and also the American Board of Urology since 2013. The process now essentially involves the requirement of a fellowship in this field, and then obviously a certification exam after that fellowship, which we'll discuss in a moment. I wanted to discuss sort of the history of this with Gary. So Gary, when did you first certify?
The first year it was offered, which was in 2013.
And what was different about the candidates who could certify at that time versus now?
So at that time, there was a period of time where people could be grandfathered in. Essentially, that meant if you had a certain percentage of your practice that was devoted to this specialty, and that review sort of certified that or verified that, then you were permitted to go ahead and take the qualifying exam, the certifying exam at that time. And so that extended, I believe, for 3 years. And once that 3-year period window was over, then it was only people who went through the formal FPMRS training that would be able to get certification.
Right, and now, as I mentioned previously, the only people who can sit for certification are actually candidates who have completed an FPMRS recognized program. There are roughly 45, 46 programs that are certified by the American Board of OB-GYN, and there's roughly 15 programs that have a urologist as the program director and are what are considered urologic-centric. Gary, for those people who have completed the original certification back in 2013, as you know, this is the year for all of us, you and I both completed at the same time, for us to recertify. What are the aspects of recertification in terms of what candidates should know prior to actually the examination?
So first of all, people should know that there is a window. This is, as you mentioned, the first year you can take it. You do not have to do it this year. There are a couple more years that you could take it if you don't feel ready or able or wish to take it now. If you do wish to take it now, then the certification process, the recertification or lifelong learning process, is available in the Diplomate portal and very self-explanatory, but essentially in a nutshell, there's a certain CME requirement that you need to verify, and a portion of that CME needs to be in the female urology, female pelvic medicine, reconstructive surgery area. You must submit a complications log, mortality log, and then your log review. And your log review is really basically over, I believe, a 6-month period that's then annualized to sort of say what you do in your practice, both in the office and in the operating room, and then that will be evaluated by the American Board of Urology to make sure that you're able to sit for that recertification exam, so to speak.
Yeah, it's very important to stress that that practice log should reflect a focus of the practice in this field of and domain of care as being a very important aspect of things. So Gary, obviously you mentioned those elements that are critical for, if you will, the application. For candidates who are now thinking about how best to prepare for the examination, what would you recommend?
For the lifelong learning examination, so that we do, like all lifelong learning exams in the American Board of Urology, there isn't part of that is considered core urology. We recognize that most of us who are practicing are also going to have other aspects of their care that are core urology, so that will cover the breadth of urology, which may include urinary tract infections, other aspects, BPH and so forth, voiding dysfunction. We try to be very, make that applicable to most. And as is well known, a lot of this, the questions on the exam do come from prior SASP exams. So we certainly encourage people to study from SASP and other sources so that they prepare themselves. So in addition to that core urology, most of that exam, roughly 2/3 or more, will be focused on female pelvic medicine and reconstructive surgery. And we try to make it sort of what the most urologists out there who are practicing FPMRS would see on a regular basis, with prolapse, incontinence, voiding dysfunction, neurourology, covering all those aspects.
Regarding the core part of the examination, it's important to also understand that perhaps the best preparation can be done by looking at AUA products such as the self-assessment examination, and clearly those exams have questions that have themes, common themes that will be seen on the examination. The other element that we strongly recommend the candidates look at are the core guidelines and AUA practice statements, as they are very important for practice standardization purposes, obviously. It's also important that everyone realize that the exam is different than it used to be. There used to be a pass-fail element. Gary, do you want to speak a little bit to that now?
Right. So while we still look at the exam and the exam results and can sort of verify where you as an examinee sort of sit with regard to other people, there no longer is sort of high stakes in the sense that you can fail. If there's an area or areas that you are weak and that we think that there can be improvement, we will then recommend CME in those focused areas to allow you to educate yourself in those particular areas. So while we certainly recognize that it's an important part of the certification process to go through this, we also recognize that our goal is to help you become better physicians. And so through this exam and through CME requirements after the exam, if necessary, I think we certainly achieve that.
No, I would agree, and I think it's important to realize that the recommendations for CME are based upon areas that may segregate a person from the majority of people who've taken the exam based upon statistical standard deviation. The goal, though, is obviously we all regard CME as a self-improvement activity, and so the CME obviously is a directed CME towards areas that may have resonated from the exam that the person may need to increase their knowledge base or comfort with that specific area of knowledge. Let's talk a little bit, Gary, about the initial certification process. So this is now a person who's completed a urologic residency or gynecologic residency, but mainly urologic, who now has gone in urology into a 2-year training program, has completed that program. What does the process look like after fellowship graduation for the individual?
So unlike the lifelong learning, which is completely an ABU delivered product and ABU recertification, as you mentioned, the initial certification is done in combination with American Board of Obstetrics and Gynecology. So yes, you go through the same process of submitting a log review to the Board of Urology, much like you do in the recertification and all the requirements of that. The actual exam itself is done in conjunction with ABOG and is a very varied exam covering all aspects of female pelvic medicine and reconstructive surgery, including prolapse, incontinence, voiding dysfunction, neurourology, and many other domains. So it's a bit of a slightly different exam than the recertification exam and the breadth, perhaps, and it is done in conjunction with ABOG, and that's important to know. But as far as the other aspects, the log review and the CME and that type of thing, it's pretty standard with the Board of Urology.
Right, and for the initial candidates, it's important to realize that, as Gary mentioned, there are certain elements that are actually different from the urologic-based lifelong learning exam. So the initial cert exam also includes areas related to, for instance, statistics, pelvic organ prolapse classification and quantification using the POPQ basis, and those areas are for some perhaps a little bit of a surprise, but that is part of the conjunction between the ABU and ABOG. Those elements are considered important to stress for the initial examinee versus the lifelong learning examinee who will not encounter those. I think it's important to realize that the certification process and the lifelong learning process will continue to evolve as the ABU and ABOG take guidance from the American Board of Medical Specialties, which is sort of the overarching group, and there will be an evolution more than likely in the lifelong learning process with the goal, again, of making it more facile for the individuals who are recertifying and also more valuable. And we're very sensitive to that, and we very much want it to be perceived that we're being listening and being reactive to the board diplomate's interests, and also trying to make this as worthwhile a process as possible. But I think it's very important to remember that a lot of information exists and resides on the ABU website, and there's information there. But there's also another channel, if you will, for contact with the ABU, and that's phone calls to the office. The office is very customer-centric, customer-friendly, and you will always be able to call and find a person during regular business hours, and will get help and direction for any questions that you may have. Gary?
No, I agree. I mean, there's been a lot of work done on the Diplomate portal over the last few years. It's much more user-friendly than it's ever been. But if you find any troubles, you have any difficulties, as Roger mentioned, a quick call to the Charlottesville office will clearly solve your problem. So I encourage you to do that if there's any issues. But doing it myself fairly recently, I found it to be very facile.
Well, we hope that this has been informational for you. Again, please remember the relative ease of calling the office should you have questions. We do want to work with you and make this process, again, as facile and as easy as possible for you as you move forward in the lifelong learning and also the initial certification elements of the specialty. Thank you very much.